All right, we'll go ahead and get started. Good afternoon, everybody.
Afternoon.
I'm Dale Devon, District 5, which is St. Joe County, which happens to be the home of the Fighting Irish, for those that may not know it. But we're going to go around the room and introduce ourselves a little bit.
I'm Emma Blackwell, Youth Representative.
Jada Cuttress, Youth Representative.
Jeff Helm, Youth Opportunity Center.
Janine Jacobs, Family Arc.
Aaron Atwell, The Villages, filling in for Shannon Schumacher.
Dr. Brunsma, South Bend.
Good morning, Mr. Chairman. Senator J.D. Ford representing District 29.
Representative Victoria Garcia Wilburn, House District 32.
Representative Alex Burton, District 77, Evansville.
Tina Clore, Firefly Children and Family.
Jennifer Dorfmeyer, Director DCS.
Dana Kenworthy, Court of Appeals.
I think Mark Fairchild, I don't know if he's going to join us like today or not. No, he's going to stay back on the site. And I know we have some folks online. Shannon is with us. Shannon, can you hear us?
Yeah, hi, Shannon Schumacher with The Villages.
Very good. Anybody else online? That was it. Okay. Everybody here, everybody okay, or do we need to turn the volume up a little bit? On maybe I'm just getting hard here. So speak loud and into the mics when you're speaking, but we'll go ahead and get started because I know we got some storms on the way. Sounds like so. Hopefully I hear everybody on a good time and get everybody home safe. So with that, we're going to go ahead and jump into old business real quick. And I know you all have a packet. Does everybody have a packet? It says Child Welfare Task Force on it with the Indiana House on it. Yeah.
I have extras if anybody needs another copy.
Everybody in the audience need one. Great. So, and with that, I know Jennifer, you just want to explain just a little bit, and then we'll move on with that. I know there's a lot of information in there with the old business, and she'd encourage you all to review it and then reach out to her with any questions or concerns.
So these slides that you see in this packet were from the last task force, and these were questions that carried forward. So rather than listening to me read all of these, which I don't think that you'd want to, I put you all to sleep. I wanted to just give you that packet so you can review it. And if anybody has continued questions or things after the fact, feel free to reach out to me and I can get clarification for you.
Comments real quick before we move on.
I just have one comment. The structured decision-making system that you have in its current form, have you done, or has DCS done any, because you have a lot of data, have you done any work with one of the universities to do some research on it?
Not since I've been here, but that's a pretty short tenure. I can ask some questions to see if anybody's done that prior to my arrival.
Okay.
Dr. Brunsma, which university are you affiliated with? Are you affiliated?
Bethel University,
Where is that located?
South Bend or Mishawaka.
Okay, thank you.
Yeah.
Any other questions or concerns? None. So with that, we'll go ahead and move on. I know we have a presentation on new business with home-based services, and I think if you want to come up and introduce yourself.
Okay.
We're not doing it yet.
I'm actually gonna jump in real quick.
Yes.
We had a slide. I didn't. How do you just click over like this? Oh, here it is. Whoops. There we go. I just wanted to put this up here to kind of level set where we are. The federal government had a journey that they represented for Idaho and how our current ACF director saw their journey through the reductions that they made and kind of outlined where the money goes and where the spend is. So I asked them to put this together for us in Indiana. This is actually very new to me as well, so I haven't had a lot of time to study it, but I wanted to give you this opportunity to look at it, absorb it, and just kind of level set to where we are with where our kids are, where our money's spent. If you look up in the corner, and my glasses are readers, so I don't think they're going to help me here, but the number that's 30,000 something That indicates the spend, I think. Can I have the slide?
Families.
That'll make the readers actually work for me here. So, no, sorry, 36,988 families served. And if you look at the $4 and that's those served in prevention, and the $4.25 is the average number or the average cost per child in prevention. So when we think about how do we move kids through the system, which is less traumatic, typically better outcomes, why we're thinking about pushing more children through the prevention system, less through involved status with DCS, because not only is it the right thing to do, it also costs a great deal less. So I just wanted everybody to see this slide. And then this slide represents the number of children that have been involved in foster care and has been on a steady decline, but you match it with the annual expenditures and you see where the costs have continued to rise while the number of kids have declined. And so I think that as we're moving through our journey in this task force, it gives us an opportunity to start asking the questions why and to see where we can impact that. So, and I'll get this all out to you in email. This literally was just created. So I thought it was a great slide to kind of give us an opportunity to absorb that and think about these things as we move forward. Thank you. Go ahead, Austin.
Thank you, Jennifer.
Hello. Hey, Jack.
Just introduce yourself.
Austin Hallball, Division Director of Child Welfare Services for DCS. And we were asked to present on some of our resources as far as home-based services as well. I will also speak to the older youth services and any gaps that we had and have identified. I listed out 3 services, and after he told me how to use the clicker, I left it sitting there. My apologies. That we probably struggle with the most. This isn't an exhaustive list per se, but the child hearsay evaluations and psychological testing is something that we probably spend a good amount of time on trying to find providers that will meet our needs. There are several reasons for that. One of them being for a child hearsay evaluation to be complete per Indiana law, it has to be a psychiatrist, a psychologist, or a medical doctor, the primary care physician. I don't think I've ever seen a primary care physician that is willing to do a child hearsay evaluation and testify in court. Likewise, I'm not sure that I have seen a psychiatrist do that either. So it pretty much falls to the HSPPs, to our licensed psychologists. Rightfully so. I mean, that is a very important legal matter in that, and I would defer to Judge Kenworthy to correct me, certainly. But it is a very sensitive matter for the purposes of our judicial processes. And so it should be held to a very high standard, but it definitely doesn't allow for more access to it. Likewise, the psychologists will and do share the burdensomeness of having to testify and sit in court and wait. We all understand, any of us that have ever had to have something on a docket and you have to wait, and their time is valuable to them. It's less clients that they can see. Likewise, a lot of them are traveling long distances. Most of our psychologists will do the evaluations or the psych testing for any county, depending on transportation to get the child or the parent there. But then having to drive across the state to be able to testify in court is a burden that we've tried to ease over the past few years. But it is difficult, and some of them have literally stated like, we don't want to do this anymore, or we're not able to do this anymore. And we've lost people for that. Likewise with the testimony, guess going into that, just the burden on them, it is a lot. And they sometimes have to sit there for 6 hours to then not be called in. I'm sorry, I'm looking at you. I know you would have never purposely done that, and I don't think it is ever that. It is just a function of our judicial system, and people have to wait. Likewise, I will say SHRI, but the sexually harmful reactive youth is a specialized service. It is mainly used by our JD for the juvenile delinquency. So that requires a CSAC per our service standards and per best practice. They are a commodity. They have expanded that. ATA has expanded that training and made it more available. So we do have more, but certainly, as you will see with the next two and maybe even three, geographical constraints arise from that. That yes, we have plenty of them in, let's say, Marion counties, Lake, Allen, but when you get into rural counties, it's much more difficult to find somebody that is trained in that service and able to provide it for us. Not that it's not out there or doable, but capacity comes into that as well. There's a lot of group work with that modality, or should be. And sometimes that isn't always available when you have one child referred from a county. It's hard to run those sorts of programs. Likewise, batter's intervention or aggression intervention, which is certified through ICADV. They have expanded, certainly since the pandemic, their availability to be trained in that. The costs have reduced. It was a very substantial amount, in my opinion, 6 years ago, 7 years ago. They've definitely worked to make that more available, and we do have more. They've also allowed for some virtual, which we have feelings about at times, and I certainly do, certainly with the standard, but at the same time, it has allowed for some more rural counties to be able to have access where there isn't a program available to them. And then
Can I
therapists.
Jump in
Oh.
real quick for you.
Of course.
I want to just highlight this because I think that while we did add the data here and it's difficult to sparse out, domestic violence is one of the top contributors for intervention. And I think that this is an area that we lack external expertise and support as well as internal. So if you have, we have a lot of women's services and children's services, but we do not have better services. And yet we still need to work towards reunification. So oftentimes I think you see cookie cutter case plans and service plans for these folks because we don't know how to refer it correctly and or the service isn't there to refer it to. And so if I had to pick an area, this would definitely be one.
Yeah.
It also takes 26 weeks to get somebody certified to be able to do that service. So when we want to get somebody certified to do, we do batter's intervention at Firefly, but the training for that is 26 weeks long. So it takes us a full 6 months with somebody participating in 26 sessions to be able to get them certified to do that model.
Because the program is 26 weeks.
Yeah.
And if I can just add to that a little bit, I know, we created a pilot program for family resource centers in Indiana back probably 7, 8 years ago. We had 5, and now we're up to, I think, about 13 or 14 family resource centers around the state, if I'm not mistaken.
Mm.
I think it's a little higher.
10.
I think it's 10 official ones, and then we have a couple that are kind of lookalikes.
Okay.
Yeah.
And I know the data that came out, I think,
Mhm.
I don't know, Tina, if you were the one sharing it, or it seemed like domestic violence dropped 30% in those communities that had this family resource center.
I think their actual involvement, maybe substantiation,
Yeah.
that statistic was around their substantiation rate in those particular communities. Yeah.
I think we've seen a lot of great things in
Yeah.
the communities that have received a family resource center, sorry. I think a lot of the metrics around that, which I do not have with me, but I do believe that we have seen a lot of those metrics improve based on the fact that they have that in their use. And Tina could probably speak a lot to that, to the use of them, because they know how many people are going through the door daily, weekly, and receiving what from those centers. It's been a very good thing.
And I'd like to see that expand somehow, throughout the state as much as we can.
Now, my question was to that point, like, where are those centers located throughout the state?
So I know we have Grant County, Delaware County, Marion. Tina's gonna have to help me here when
We
Jay,
have one in Jay. There's one in
Elkhart.
Elkhart.
Is the port just open up one as well?
Yes,
And then-
it got moved.
I don't
think
know
it
that
was-
there's any south or one.
Um, Maybe not, because we initially the areas that were targeted were our high child fatality areas. So it was started out as a grant with IU. And so we targeted specifically like areas that had high child fatalities. And so that's kind of where we started. And it wasn't so much about what part of the state they were in as what their child fatality numbers look like. I do know, like we've been in talks with Shelby County. We're trying to help them get one up and going. We're supporting them and trying to make that happen. So yeah, I think part of it has also been around which communities are ready for it, because it is kind of a community-led model. And so it's not something that we as a provider decide that your community is going to get this. It's more like that the community wants it and wants to be involved and they want to engage with us because that's how it works best. So some of it is about that readiness.
Well, I'll talk to you because I'm volunteering in Brandenburg County. We have stress, not just being.
We do the technical support for the whole state.
I agree with you on
Yeah.
that.
I just met with Sarah earlier this week, so.
Good.
Yeah, and I can speak to Jay being that grassroots because they saw within their area that Grant and Delaware were, received one. And that as a community really pulled together, said, we want this. And they brought it and made it happen. So it definitely takes that community pull to want it to be there. So thank you for that. So the last thing I have on there is this is not an unknown to anyone in this room, just the workforce that we have that was probably highlighted the most in, when the pandemic hit, it's still real. And getting licensed therapists, certainly that in all parts of the state is not something that is taken lightly. And being sure that they have training, right? Like what evidence-based models that they have available to them and them utilizing them. But we certainly have areas and counties that do not have the workforce resources that others do. And so there's times that, a provider will say, we literally do not have anyone that we can assign to them at this moment. We will work on it. We'll see if we can switch some things. But that is a reality that we deal with within the system. Is just trying to ensure that we do have those resources available. I'm sure I can come up with an example of pretty much every service of one county that may not have something or does. But those are the big ones in my world that I have to try to address pretty much all the time.
From this morning, and forgive me if I get this exact data point wrong, but Kids Count data came out, and for mental health professionals to child, it's one child to every 441 providers. Is that right? Yeah.
How well are we doing with educating graduates about the Indiana State Loan Repayment Program that's specific to mental and behavioral providers? I don't think we do a good enough job of advertising that throughout the universities and for new graduates to attract them to underserved areas. If they believe it's about $20,000 in loan forgiveness, and if there's some sort of coordination or partnership that we could roll out, I think that would be advantageous.
I would agree. And I know very little about that myself. So
it's rarely taken advantage of. The last time I checked, there had only been 3 people that had applied to the program since its inception, and I think that was 2014. So we have a lot of money to be able to award in the form of loan forgiveness for residency exchange and service provision.
yeah, that's something that I would absolutely speak to my providers about as well, because them knowing that and being able to advertise that as something is worthwhile,
Right.
because that is where we struggle. And I think it's a business model too. I've been a local office director in a couple counties, and I had seen that in a mid county that's close to a large county. I have a therapist that maybe is assigned to, half my cases or half my kids. and then they're transitioning. And I had to ask, you know, what's happening? Well, they're going to go to the urban center where they also have an office because they can see more clients. And I can appreciate that. But it doesn't change the reality that we have this need.
I can share the information with the group so you all can continue to disperse that.
Yeah, I would be happy to share that in my meetings with providers.
We would like
That would be
anything that
good
makes
to-
it more appealing to work with
Yeah,
us.
yes.
I mean, it's
That would be-
difficult because we can't compete salary wise with the hospitals and the schools. They tend to take our staff about as quick. We do all of the work of getting them licensed and provide their supervision for free. And then as soon as we get them licensed, the schools and the hospitals snatch them up. So it's very difficult for us to compete on that front.
Yeah, I couldn't agree with your point more, Tina. Like, I think, you know, for us, we can't hire enough therapists, and even like when the workforce is present, we can't compete salary wise.
Yeah. I think that that's a really good point too about, you hire somebody, you train them, right? And then they move, and that's difficult. Certainly.
Yeah, Austin, on the child hearsay evaluation shortage, courts can do better. So if providers are sitting there waiting for 6 hours, that's not something that should be happening. So to the extent I can be a liaison and help problem solve some of that, I would be willing to do that. And as for the testimony, I hear two things in that area. One is the waiting, the travel, all of that, which I also question because of remote access these days. But I also hear sometimes the fear of being cross-examined. And so that's a solution that I probably don't have.
Yeah.
But on the other side, I think courts can be part of the solution to the extent I can help. I'm happy
Thank
to
you.
do so.
I have two comments. One is on that information Representative Wilburn was talking about. That does not get to the universities. And I've gotten at least 4 graduating seniors from the university down into MSW's programs these days. So that would be very helpful to have that information in the psychology, social work programs in the state for all the universities. That might really pull people in.
Absolutely.
I can directly talk about the psychological evaluations since I am a clinical and forensic psychologist and have done thousands of evaluations in the state. There was a problem, I don't know if it continues since I've been out for a little bit, but there were standards done by DCS several years ago where basically DCS was saying, you're going to do this work, you have to do this comprehensive psychological. Comprehensive psychological takes 40 hours to complete on average. That's a lot of work, okay? And it's very expensive. It's also not reimbursed very well. So you get, and I've reviewed thousands of psychologicals done in the state. Some are pretty good, and some, as you know, are way below standard. And then you're giving courts information that's not going to be very helpful. I proposed to DCS and was turned back in saying the model that should be done in psychological practice is you usually help the referral source define the question they want answered. Okay, that's not happening. They're doing this shotgun approach with, give me a book on this child. That makes it very unrealistic that you can get a lot of providers to jump onto that. And if you don't reimburse them at a certain rate, they're just not going to do it. And in my county, now that there's no psychologists left in the juvenile justice center there's no one doing the psychologicals. Like we used to do them. We didn't charge the state anything for it. That was just part of what the county paid for. But at one point I had 3 psychologists there. There's 0 now. So that falls back on DCS. And I think you're talking just to home-based services at this point. Yeah.
Yeah.
You know, if you don't get something good going at home-based and you don't get an appropriate assessment, then you have another problem. The other piece that's impacting is the schools. A lot of the schools in terms of the, what do you call it, the larger school districts, have not really followed through on providing psychologicals for kids that are identified as having learning disabilities or emotional disorders. They have to wait I mean, years ago, I had to take the school district up in South Bend, I had to threaten them with a federal lawsuit before they did anything. So that's another issue that's not working very well for the families. So you got children coming in, and these are real cases. They're coming in high school. They got caught up in some delinquency. Then you go back and you're looking at the records and it's like, these kids haven't even been evaluated. I've all kinds of learning disabilities, no one getting any services. It's just really unfortunate. And the time for intervention has to be early, not late. And this is another example, and I talked to Mr. Devon is going to get crazy with me, but I've talked to him a million times how the state departments don't work together to make things happen. And this is a prime example. And we've been going on and on and on with this, putting the burden back on DCS to try to do everything, which they can't do everything. You know, so there has to be some discussion around this.
Thank you.
That's my thought.
I appreciate it.
That's why we're here.
I'm also going to speak to the older youth services, which I believe maybe last fall, Anissa Evans presented to you on older youth services and the program and funding. I was down here for it, so just to relive that. We do not have a service capacity with older youth services from the sense of who we have doing it and their availability to do it. I think the gaps are more lie in the infrastructure of other things, i.e. older youth can choose to live where they want to live and they get that voice. And many of them are coming from our rural communities and there just aren't as many resources in those places. And I think many have come a long way, but that is something that kind of hinders their ability to be able to go into adulthood as they so choose. Specifically, that comes to transportation too. I mean, Indiana does not have a robust public transportation system once you get outside of the major hubs. And that affects our youth who maybe haven't had the opportunity to do driver's ed, even though we do have a program, but not everybody is able. Not everybody wants that either, but that limits them. The cost of living is definitely impactful. So our older youth services are Chafee funds. That's a set amount of funds that we have and then are utilized at cost through those older youth providers. But that doesn't change. And as we all know, the cost of living has absolutely changed. Even to rent a 1-bedroom apartment, pre-pandemic, I'll just throw out $600. We're having trouble finding a $9,000 or $1,000 1-bedroom apartment for some of the older youth that want to be independent and live on their own. And it speaks to the fact that it is a set amount and we get that and then we utilize it. With that, I'm going to hand it over to Ms.
I'm gonna jump back in because I'm that.
Or
kind of-
actually, I can wait for questions.
I wanted to touch base on the home-based services and just clarify that the question was, do we have enough of capacity? And I think that's a complicated question because technically we have enough providers across the state. What I have seen, which is difficult to quantify, is that we are over-reliant on home-based casework, which is eyes on the child. So there's a value in home-based casework. However, it doesn't have a very defined KPI or return on investment for the families or for DCS. We spend around $40 million in home-based casework right now. And it's difficult. I think it's become this catch-all bucket of we don't know what to do. So we're going to give them every home-based casework hour that we can. And so I think that this needs to be reviewed and looked at and that we need to continue to identify evidence-based practices. However, coming from the provider space, I know that evidence-based practices are difficult to obtain and moving through the fidelity is expensive for the agencies, but those are typically the programs that get the best bang for the buck for families. And so there's lots of work to do there, but technically I think these are the areas that we just have simply a shortage. So I don't want you to walk away and think this is all that we have to do. We have a lot to do in services. This is just the area where we just don't have enough numbers.
I was just, thank you, Jennifer.
Mm-mm.
I was just going to add from a provider perspective that I think we experience that. I think the baseline for evidence-based practices may be too low. Most agencies are encouraged to have motivational interviewing. That is not enough to engage with families effectively in a comprehensive way. Our agencies and agencies like mine that invest in a continuum of evidence-based practices, we're competing with high saturation in the market with agencies that have none, right? And so I do think that it would ultimately help us assess families' needs better if we standardize what we're trying to achieve with those cases with a higher bar, right? And that will ultimately mean that we have to make some hard decisions on the amount of providers, but being talking to you in the past, Austin, I do understand there is a difference between rural settings and urban settings for that problem. And there are some rural areas that really have a challenge with having enough providers. But in places like Clark County or Floyd County, you know, in southern parts of the state that I come from, we definitely have the opposite problem.
When I appreciate that feedback, I think the complication in this is as we start to try to roll back over reliance on casework, you have to be very delicate because in some areas, that's how they keep kids safe and that's all that they have. And so as we really diagnose each area, you almost have to look at this very much county to county. What is it they need there? Are we applying the right services? And the other piece to this, which I think we should not overlook, is our ability as DCS to understand what services family needs and apply the intervention. I think about this through a medical lens. How do we understand, diagnose the problem and then dose the medication? And that this workforce doesn't necessarily have the acumen to do that correctly. And so we're looking at what are better ways to map our service provision? How do we make sure that we understand family need and then also get them the right intervention? DV and substance use, I also think is pervasive in our cases. And yet I think we have very little acumen in how we dose those services. Fortunately, with substance use, the community at large offers more resources. And so there's more opportunity for a parent to receive a service that's there, but it isn't always the case with domestic violence, and those two things go hand in hand. So I'll get off my soapbox because I could keep you here all afternoon with that.
I have two questions, if that's okay. The first one, regarding the child hearsay, what is our reimbursement currently? Ballpark is fine.
100 and I'll say close to 200 because we had a rate adjustment, but 3 years ago on the strat level, somewhere.
So
it's per hour.
Okay, thank you.
And I would love to make it a per occurrence. I would
Okay.
love to make it a per occurrence. Here's an amount, maybe dependent upon what scales you've used.
Complexity, et cetera.
Give us a report and you be paid rather than counting hours and
Agree. And then Jennifer, my next question to you is MST still the gold standard for home-based intervention? Is that what we're using? I know that was the discussion a few years ago. No, it's not.
We have some MST programs, but I would not say they're widespread.
Okay.
I think there's two in the
Two,
state.
Bill.
Mhm.
Okay,
There-
same from last time.
there is more access to MST than that. Yes, there is. But I will say it is predominantly a juvenile delinquency model. Not that it can't be used, and it is with child welfare cases. We really pushed that to our probation partners to make sure that they're utilizing it. The Intrepid Center and IU, Dr. Rodriguez has been phenomenal. She is phenomenal in helping facilitate some of that growth.
Okay, thank you.
Just to note, the federal government, I think, recognizes this, the narrow opportunities through the clearinghouse for evidence-based practices. And I have heard them kind of hint out that they will be opening up some more opportunities that may not be on the clearinghouse currently.
Okay.
One quick question, and Jennifer, maybe for you or for Austin. On what you said about home-based casework and kind of like everybody's getting some of that, and it's not necessarily prescriptive or diagnostic. On the structured decision-making tool, and I know you mentioned something about it earlier, do you see that helping with more of the diagnosis, or still kind of yet to be determined? Or is it
No.
more for case planning?
No, I don't actually think the way that we use the SDM tool, it really just determines whether or not we have legal sufficiency or risk
Gotcha.
to open an assessment. It doesn't necessarily lend itself. I think there's opportunity to build tools that may, and we think about predictive analytics, or some AI generated system, which, you know, I have my grandchild tell me how to work my phone. So, but I think that there is opportunities there that could help us lead itself to, here's some services that may work for this particular family. Gotcha. We have the data.
Sure.
We don't have the data mined. We have 20 years of data, but we don't have a system that really aggregates that and tells us, here's what you can do. So that's kind of the issue.
I have one other question for you, Austin. I know recently one of my staff talked to me about, we have multiple cases where a client, a child will have so many different providers in their home, home-based providers. Is there a way to screen that or organize that? I know we want to have continuity of service and all the things, but it seems to be overused in that way.
I think I can speak to that from the standpoint of, you know, at our level, we're not making these referrals. I do not know this family or this child, but we absolutely speak to and have been impressing upon them, one, the quality of the referral. To your point, you can't get PA if it says court-ordered psych eval, right? Like that's not a medical necessity to do something. We need them to give you good referrals. And we have been really, there are many projects just trying to enrich that. Like that's the start. But there are things in place and moving towards, and maybe Amanda would like to speak to that when she's up, of reviewing those and trying to assist them in understanding like continuity and sameness, if you will, like having one provider. Why do you have it to 3 different providers when this provider could have provided all those things? They communicate better, easier. You're not having to navigate multiple agencies. Not that that couldn't be the case, but certainly when it makes sense and when it's there, having those conversations, and it is being discussed.
Just a comment on the MST. As I remember it, it's a pretty expensive rollout for that model, and it's very difficult. There are some equivalent models. And the MST research, I don't want to give you a dissertation on this, has some questions about that too. And then you have the idea of when you train people in MST and they get their license, they're gone, okay, because they become more valuable. So it might be a good thing to kind of look at some other models that maybe are more affordable and that you can have trained the trainers within your department so you're not having to spend so much money. You know,
The models are selected by the federal government.
yeah, I understand
by them.
clearinghouses and all of that.
Yeah, I mean,
But
they
there are-
really have
There are other
restricted it.
things in the clearinghouses that you can look at. MST has been held up as this somehow gold standard, and I quite honestly disagree with that.
I do too. I think with a lot of the evidence-based practices, for people who don't work in that, all it is a tool in your toolbox. And it only works if you have a screw and a screwdriver, and it's kind of like taking a screwdriver to everything. It doesn't work for a lot of them.
It's also workforce prohibitive
Oh,
to some
it's
extent.
very much
right?
so. And it's
Time.
6 figures to get it going and lots of years of time.
Dr. Rodriguez really helped with that from the standpoint of the
Very expensive.
yeah, getting it rolling. But then you have 4 workers assigned, with an HSPP over it that can only have a certain caseload, and it's restrictive in that sense too.
Yeah, it's very difficult.
Yeah.
I wanted to address some of the stuff with older use services that you talked about. So you talked about the housing piece of it is such a huge issue. Like, I don't think that can be overstated. Like, there are 5 agencies who have the state basically divided up. We have areas that we serve, and we serve all the youth in those areas that are aging out of foster care that are referred to OYS. And we could rent a place for them to live in 2019 with the amount of money that we were getting, and we could give them, it was meager, but a grocery budget, and maybe they would only have to work part-time while they were also trying to finish high school or go to college or technical school or whatever they were doing. Now I was just talking with some of our staff today, like our kids are renting a room because that's all we can afford to do is rent a room. And so you end up with what we have, 3 special needs kids who've grown up in the child welfare system, now all sharing the same house, which is not the most conducive situation. And there's something called Foster Youth Initiative housing vouchers, but they're not consistently available across the state. So like right now, Jada just told me there are like 12 referrals, or I think it was, there are like 12 spots open in South Bend. So if the kids want to get a housing voucher right now, they need to move to South Bend. Indianapolis is notoriously horrendous. We never have housing vouchers here. So for all the youth who live in Indy, or any who would want to come here to go to school, or because there's more employment opportunities, our vouchers were run through Indianapolis Housing Authority. We could never get any. We always had less than everybody. And last year they suspended all of them. So there are no housing vouchers for foster youth aging out in Indianapolis. And it's not just Indy, it's other parts of the state. So having, like, as we're looking at solutions, having consistent access to housing vouchers for youth that are trying to age out and finish high school, go to technical school, figure out how to have a job, would be such a huge improvement, because it's a real challenge. And then, as he mentioned, like the amount of money we get to put the youth out to get them going has stayed the same for I don't know how long, for very long. And inflation has taken its toll on all of that in terms of the cost for transportation, food, and housing, and them to have a telephone. So it is very difficult to be able to serve the youth with the amount of money that we have. Most of the funds for OYS are federal funds. Our federal funds were decreased as a state because our overall foster care number went down some years back. But when it went down, the number of youth didn't go down. It was a disproportionate. Younger kids were not coming into the system at the same rate, but the older kids stayed the same. And then the federal funding was cut. And so it put more pressure on the state funding, which, is pressured. And so I think, that has all posed real problems to serving the youth that are aging out of foster care. And they are a very high risk group of young people. They have had a lot of trauma. They are years behind developmentally, emotionally, educationally, many of them coming out. And, but they have so much potential. So, it's, as a state, it seems like we need to invest in them. We should invest in them. And I think we have, compared to other states, we have a really great older youth services continuum of services. But some of the environmental things have really come into play, like the variance in housing and whether or not you have access to that, the variance, and whether or not there are mental health providers. The youth are, when they hit 18 or whatever age their case is being closed, they're kind of tired of being told what to do. And a lot of times they need a year away to go find out that maybe they don't know everything like all 18-year-olds think they do. And then they come back. But there's just, and we are able to serve them, which is great. As a state, we're able to serve them up until they're 23. But if all of the kids that are eligible for those services came back and actually tried to access those services, we do not have that much money in the state's budget. Like there is not, every kid's eligible for $1,000 and there are 450 of them, there's not a multiply it out and it equals that money is not there. So we are pressured to try to serve them with less, and they have just a lot of needs. And they also have a lot of potential, and it's to our benefit as a state to help them get on their feet and get through that. And this is not about DCS at all. It's just kind of the state of things. DCS is a great partner with these young people. And, I love that, that we have Jada here and that we have young people here representing the other youth. But the reality is it is challenging right now, just because of the environment we're operating in.
Can I go back to when you talked about, I guess we talked last year about the software that we're trying to create, right? And are we getting anywhere with the software program that would help determine as far as services and keeping kids close to home and
Yes and no. So the federal government just offered a grant opportunity for predictive analytics, and we threw our name in the hat right away. So that is as far as that's gone. So I don't know the next step to it. Have had lots of conversations about it, and we definitely have built in the ask for next year's budget to look at not just we looked at a software for foster parenting and foster parent license and how we communicate there. Also, our CWIS system, which is our computer system for child welfare, and some data analytics that would lay over top of that. So we're in progress, but there is no answers at this point.
is there a state that has it available that we can emulate it or not?
I don't believe anyone has the whole package yet, but there are states, Idaho, I believe, has some good things happening with predictive analytics. And the ACF, our federal partners, are putting out a dashboard or a roadmap so that everyone can share their experience and we can talk with one another as we can share implementation strategies and things like that. So they're definitely focused on it. I know more will happen here. It's just not there yet.
Thanks.
So, hi, I'm Amanda Ressler, Chief Deputy of Child Welfare Services, and it's a newer title, so I keep getting it tripped up. But want to talk to you all today about licensed foster homes and kinship homes, and we're also going to talk about residential as well. So this just kind of breaks down our total licensed homes in the state of Indiana. Our relative kinship foster homes only are 497, non-relative DCS homes, 1,532, and LCPA licensed foster homes, 1,744. So what this looks like in the breakdown when we have 8,000, boy, these numbers are small, 8,778 kids in care. So those are youth that are actually in placement. And then in comparison to the 3,773 homes, we're sitting at where we needed 2 to 1, 2.3 times the licensed homes we need to reach our 1-to-1 ratio that we're working towards as we work through a home for every child with our ACF partners. So to see the discrepancy of home to child ratio is pretty significant.
Can I, so, but I'm assuming there's siblings involved versus they might get 2 or 3 kids per home or?
Sure. Yes, yes. So we would always want to prioritize sibling placement. So we would want a home for, for that sibling group.
Just some clarification, federally, we would join the Home for Every Child. And so the number they asked us to get to is 1-to-1. So that's the ratio we're shooting for, while it doesn't account for the sibling groups and things like that. So, but that does exist.
Yes.
Amanda, quick question.
Sure.
So out of the 8,778, 3,773 are unlicensed homes. The other portion are either in residential setting or an unlicensed placement. Is that correct?
So we may have, out of those 8,000 youth, we may have multiple kids in a single home.
Sure.
Yes, and then we might have, but those are the only licensed homes we have. So we have at 400 and whatever that number was, 497 of those kids would be in potential, are in kin only homes. So they're not licensed, but they're relative homes.
Okay.
Yeah.
We do
So-
have another slide on residential that's coming
Yeah,
too.
and it's, yes, we do. So yes, the other kids that are not in current placement and don't have that would be sitting in our emergency shelter cares, in residential facilities, group homes, and those sort of congregate care type settings. LCPAs, and this is just kind of a breakdown. We have 29 licensed child placing agencies across the state, 1,744 licensed LCPA homes. That doesn't necessarily mean that those licensed homes are available to take kids. They might not have bed space. They might be taking a break from foster care at the moment. There might be a hold for whatever reason, or they maybe only take certain types of children within their home. And so that doesn't necessarily mean that all of them are at capacity, if that makes sense. We do have a wide array of our LCPA providers, and they do cover the entire state. So we don't necessarily have gaps in where they're able to cover. We may have gaps in where we're able to find foster homes within those areas.
Can I ask a quick
Go ahead,
question?
please.
And this may not have been implemented yet, and Representative Devon, please feel free to help me. But this year we passed a piece of legislation regarding religiously affiliated placements. Is that number going to be accounted, and will DCS have regulation over those like religiously affiliated placements, or is that an entirely separate entity?
Go ahead.
So are you speaking of the religious homes that would take families outside of the system that are not taking foster children? Or are we talking about like Sunrise would be a religiously affiliated LCPA?
I can't remember specifically what the legislation outlined.
I was a Sunrise.
Okay,
Sunrise,
yes.
yeah. They are still working through contractual issues. So I think at some point they would be added to the 29
Okay.
LCPAs. Right now, though, we have several that are already religiously affiliated. So
And they are under the DCS umbrella, still
Correct.
maintaining the statute.
yes,
Okay,
they have
perfect.
all of the same licensing guidelines.
Thank you. Thanks.
Yes, absolutely. And just to kind of highlight some of the top inhibitors, the availability of clinically appropriate homes. So we may have licensed homes that could take a child that doesn't have a high acuity, but we may need a home for a youth that has a higher acuity, may have medically fragile needs. And so it would need a specific type of foster home to handle those medical needs. Also homes that can take larger sibling groups so we can keep them all together and ensuring that they have the bed space and capacity. So there are other things that happen within that. We would like to see us be able to create a higher acuity, LCPA home that they're able to take, and we're able to support kids within those homes. Let me see here also.
While you're looking, I'll just throw out an interesting statistic. I heard that if every church in Indiana had one foster family, we would cover all the need for all the kids. So I thought that was kind of eye-opening.
Yeah, and I'll jump in here too real quick. I think on that first slide that you'd say, the 1 to 2, and you're trying to get to 1 to 1. I don't think that number does it justice, right?
Sure.
It's not a number thing. I think it's a match thing as well, right?
Yes.
So when you talk about the acuity of children, and I mean, yeah, we can get to a numbers. Definitely don't have enough foster homes, but I think it's the mix as well. And I think, when you think about all the filters from licensing down to placement, right?
Mhm.
There's so many different filters that are on, whether it's the age of kid, the acuity of kid, whether there's been a legal background or whatnot. And then, as you'd said, some are taking breaks. And so it's just decimated right now. And I think recruitment is big, but also retention, right? I mean, we're losing half of our foster families within the first year. And so how do we not just focus on recruitment, but also on retention?
Right, absolutely.
Yeah.
How do we support them the best way we can?
Well, and at Jennifer's point, I think if every church, synagogue, temple, mosque helped with the preventative side,
Mhm.
then it would save even exponential money and families wouldn't even enter the system. So I think there's lots of creative work to be done.
Absolutely. And we've been also talking about our creative space around kin homes and relative homes. How do we support them better? So that way we can get them to take, their relatives into their home, as well as how do we get them to licensure faster? Is there anything we can do on our end to really help support our relative homes?
We do have the intensive foster care program, which is designed for those kids that have more of a complex need or what we call high acuity. It is a wonderful program. It offers a higher per diem and also services. Problem is it was unbudgeted and it's pretty expensive. And so we are pretty selective into how kids fall into that. But it is another way we also can support kinship providers that have these children in their care and oftentimes are less likely to disrupt than a home that may not know that child.
Director, do you see intensive foster care further limiting capacity of foster homes?
No, I think we are where we are. I think this is the level of kids that we'll probably maintain unless at some point we can widen the scope.
Any other questions on LCPA?
I think one thing that would be beneficial is matching our young people better with foster parents that fit for them. It would be nice in an ideal world to have like some type of AI generated thing to ask young people, are you okay going to church on Sundays? Are you okay with what do you want me to call you when I introduce you to people? And just being able to be mindful of what the foster parents want, because they are doing this as a service and helping, but also making sure that young person is matched with someone and not creating more trauma for the young person.
I 100% agree with you. The other thing that I think would be really beneficial is if we could connect our foster homes and kitchen homes to our 988 mobile response system, and that these people can meet these children up front, because in Jersey, they were able to proactively do that with a group of 60 kids that were the frequent disruptors. And they, within a year, none of them moved because they always had somebody to call, always had somebody to text. Yes, it was really neat.
And one way we're looking at that is in Elkhart County, we've started piloting. How can we connect better to our MRSS, to our mobile response, and do that proactive approach with all placements? So it's in the infancy stages, but that's where we're starting, and hopefully to take it statewide.
And I think just my last comment, I think when we tie all this together, the FFPSA and what that, has done and great in preserving kind of the family and the placement at home. What I think that's also done is push more of those high acuity kids right into those foster homes that may not be suitable to take those. And so working on, again, that correct match, from going to church on Sundays to making sure that we have the ability to support the children in the home, because that's what's important.
Mm-hmm. Oh, absolutely. To touch on residential, DCS is contracted with 52 residential providers across the state. There are 109 residential licenses across the state, 400 CHINS youth in residential settings, 455 of youth, aside from the 400, but 455 are our JDJS kids that are in a residential setting. And just to kind of break it down further into emergency shelter care, we have 75 CHINS youth in emergency shelter care. And just to give a little shout out, that number was over 100. And so they are really working hard to get those youth into foster homes. So 75 of those youth are CHINS. 43 of those CHINS youth are recommended for foster care, not residential. So those kids can go into a home outside of shelter care. 3 of those CHINS youth are recommended for residential care. 56 are JDJS youth. And I don't have the breakdown, I apologize, for those 56 if they are either foster care eligible or residential.
I wanted to highlight the emergency shelter slide, because this to me demonstrates those kids without placement. So they are in limbo. The difficulty is that our population changes. The kids in limbo don't always have the same diagnosis or the same issues, and this fluctuates. As you heard, it was 100 not long ago. And so when we do their evaluations, though, the majority of them still rate as if they could live in a community setting in a foster home, in which they do when they're in shelter care. And so that's kind of the issue. It sort of one issue compounds to the next. We don't have the right foster homes or the right placements that match the kids.
So from your perspective, Director, is there enough crisis diagnostic care being given in the state?
If we can connect better to what DMHA and FSSA is doing with mobile response and stabilization services, we don't have that a robust system for youth at this point. We have sort of a adult children mix, but they're not connected to DCS, which is very interesting to me and harder than I thought it would be to get 4,000 people to refer to it. They also have 23-hour stabilization units. They have CCBHCs. We are over-reliant in simply using home-based casework. Our staff seem to live in a bubble where it's hard to get them to refer to use the CCBHC, use this mobile response service. So I think the answer is unknown. I think we might if we were able to tap into what's out there.
Yeah, I think sometimes the mobile crisis things, at least what I've experienced, they have a difficulty with actually utilizing for the really high acuity youth, getting state hospital beds. And that's where this cycle starts just cycling around. And if the child does commit a detention, like a juvenile delinquency, they get stuck in a detention center for a long periods of time, which is not helping anybody because they're not getting the right level of care. And this, again, I will point out, and I've pointed out every time I'll come to this meeting, that the state government, the different agencies are not working together on this issue. And that's why our mental health system is collapsing in the state. There's a two-tier system here. And one depends on huge amounts of funding coming in from the state to maintain children in residential, right? But on the community level, the mental health providers are just not doing the work. And they can't get the kids that are really high acuity into the state hospitals. And then the state hospitals are actually trying to push the kids back to DCS through the emergency shelter cares to do diagnostics when they were in the state hospital already. So there's a real disconnect here. I mean, we talk mostly around this whole issue of residential and providers in the state and DCS, but it's a lot bigger than DCS. It's juvenile corrections. It's the Department of Mental Health that's been shrinking and shrinking. So we're doing what we did to the adults years ago and putting them in jails and detention centers. And it's not worked. People die on the street. And then you do crisis stabilization, either for children or for adults in this state. You throw them in these psychiatric units for what, 48, 78 hours, 72 hours? They met them up. I almost had a good friend of ours die from over-medding this last year. Then they said, well, she has Parkinson's. She has no Parkinson's. She's over-medicated. And she literally died. She's now in rehab trying to get back all her functions. So it's really a crime that we can't get something going. And I'm talking to the legislators here that, you know, start getting the agencies within your own state government to work together, because you can't put it all on the back of one agency. They got to work together. You can't put it all in DCS. You know, you can't throw them all in Department of Correction, you know, and think, you know, that's going to make a difference. You got to make all of them better. They got to talk to each other. We're serving the same kids. Sorry, I'm getting a little passionate about this.
Yeah, I like it. And I agree with you. I think there's opportunity for us to connect and work with our sister agencies, especially now that we're in the same vertical. And we're very fortunate now that Sarah Sailors came from DCS and I came from a mental health background. So we now speak the same language. And that, I think, historically hasn't been an opportunity. Sarah wasn't able to be here today. And if we looked at states like New Jersey, they've done this. They have come together and pooled their funding, and they're able, every child in New Jersey, regardless of what system involvement they have, receives mobile crisis response, and they pay for it on the back end. They figure it out, and then they get 4 months of care coordination. And so from that system, they've been able to move every child out of state back in, except for one, because it was on the border of where that child lived. So they've had really great results. They have trained their entire system on the same like baseline EBP, which is nurturing parenting, which helps for communication and collaboration. So a lot of things can be done. I'm really hopeful that we can get there. But as we're looking, if our representatives want to look at New Jersey, I would say that's a model that could be, you know, kind of learned from.
And I would just note, you built an NDI down here. This is not functioning very well, not for the rest of the state. I'm just going to be honest with you all. And you need to expect more for all the money you've just put out. You know, big place. And I could go on and on and on, but I won't. I just really encourage people to start thinking about having the different agencies work closer together. And not every kid has to end up in a Department of Correction to get mental health services. So
I wanted to touch base back on the emergency shelter. I believe it said that there's a part where there's a lot of folks that could be living in a traditional foster home that are living in an emergency shelter. What are we doing to ensure that that's not causing more trauma to live in that space?
So those children are wrapped in services, but we also, and I think that Amanda could probably speak a bit better to the new care coordination model that we have for kids in both emergency shelter and in our residentials that has a clinical lens, where previously it was just our case managers that were having oversight of these cases. Do you mind talking about that just a little bit?
No, absolutely. We have recently started working through residential utilization model, really a framework around making sure that we are matching kids and having the right kids that absolutely need the treatment going into residential, tracking them while they're in residential, and that includes ESC. And then also the whole time they're there, we're constantly working through this framework, a step down plan to get them out of that facility and to get them into a more home-like setting. And so through this utilization framework, we'll be having very specific clinical oversight. There'll be staffing with the field from the onset. From the minute we identify that a child may need residential treatment, then there'll be a clinician following that child through that journey and then working with the facility and then working the step-down plan as well. And so we've not had that oversight over our youth that are in that trajectory. And so we're hopeful that we will see less kids going that trajectory, except for the right kids that need it. And then also them not being long stayers when they also get into residential. So that's kind of the framework, high level overview of it. Another piece to that is we have dedicated a clinician and we're working through a work group with our state hospital partners on a better system with the gatekeepers, looking at when we have kids that need state hospitalization, that we're getting a quicker access to that service. It is a work in progress and it just started that, sort of work groups around that, but we definitely identified the need for that piece as well. Another thing we're working on is our collaboration with BEADS. We have a lot of children sitting within the child welfare system that are going to need long-term care due to, their DDID needs. And so we need to do a better job of getting those youth on waiver and getting the services that they need, that they're going to sustain them through life.
I did just want to make one clarification before my provider partners get worried. We understand that each facility has its own treatment length of time. And so our clinical oversight does not intercede with that. It just makes sure that they don't get stuck there and that we're treating the family while that child's in residential. Because I know that we oftentimes can come in and try to tell everybody else how to run their program. That's not what we're doing here. We're just hoping to keep eyes on these kids so they don't get stuck or language.
I'm sure you appreciate it too. So that way they're not calling saying, hey, they're ready and and nobody else is ready. Go ahead.
Question, I'm trying to package it to where I want to go with it is, I know we're talking about the continuum of care and supporting them on a journey. When it comes to outcomes, what does that successful youth look like? And do we have enough youth who are reaching that successful outcome? Or are we just putting people through the system to say they're taking services up until they can't anymore, and then post 23 years old, if they end up in jail, that's no one's problem. It's another system that the child is now in. How are we tracking that? But then beyond tracking it, how are we setting that gold standard to make sure that we're setting youth up for success long term?
I can jump in to say that we're not there yet. I mean, we don't have even baseline KPIs in a lot of our contracts. And so we're going back to do that to make sure that just contractually we're all working towards the same goals. It is also a very complicated answer because families and youth come in individually with different opportunities and different capacities. And so what is success for one youth is not success for another. And so I would say for me, it's optimal health and safety for any family or youth that enters our system. So it's a complicated answer and we're working towards what excellence looks like for us, but we're at the very beginning of that journey.
I guess since we're at the very beginning of this, one of the things I would absolutely love to see as we're having this conversation, because making sure that whether that is high school diploma, obtaining credentials, I don't know, private insurance, something, so having something to say, okay, this is what we want, this is the outcome that we're getting, but then also rewarding the agencies, organizations who are meeting that standard. Because it's easy, just in all the things, it's easy to provide a service for the sake of providing a service. And it's a steady stream of income coming in. But until we get intentional about what those outcomes need to look like for youth, we're going to continue to be in this cycle, and more youth are going to end up incarcerated or dead than they are living a thriving life.
I love that you asked that question. I think it gets at the heart of what we're trying to do here. I think it's a very large system, DCS, and it's very hard to turn that bus. But I think in terms of community-based services and home-based services, I think that over-reliance on just doing that like a knee-jerk reaction, we're just going to throw more home base at it, we're just going to do it that way. DCS has recognized that. They know that, and I think that that's what we're trying to do to fix the system. And I would interject in there you've already heard me say this, but as a possible look, I think the whole structure of that would have to change in terms of how we incentivize reunification, how we look at quality outcomes, and I know I'm preaching to the choir here. These are all things you're already looking at, but it is, I think right now we keep taking this back around to the outcomes and finding the best qualified people to work with our children and our families. And I think this comes into play there as well, because if you can imagine you're a young professional, you come in this work to do good things, and you get to see this happening. These are hard cases. You don't see a lot of progress, and people get discouraged. And it becomes very attractive to go work somewhere else in another sector that can pay you more, or private practice is the shiny penny right now, to jump to that. So then we have a even bigger problem to deal with, this cycle continuing and less qualified people to work in our sector. And so I think if this is something that we can really get our heads around, we can be an attractive enough space to keep qualified people to help us reach our goals.
I have a question in terms of what you're talking about. How are you defining the level of care? How are you assessing that currently? Of where the family and the child are? Because we know that if we get the right level of care early on, you usually don't have anyone progressing through. But how are we doing that now?
As far as residential treatment or just services in general?
Yeah, it could be any of those, but usually someone has to assess what's the level of care needed. It's like, for example, you go in an emergency room, you have an emergency, the doctor says, well, I'm going to send Senator Ford, we got to get him to ICU because his heart's about ready to stop. We can't have that, and then other people can Representative Burton, well, he's outpatient, he just has a cut behind his ear or something. How are we assessing that? Because I see when the system does better, we're assessing really well where we start with the level of care that we're giving the child. But how are we assessing that now?
So I will tell you, just to kind of speak to where Director Dorfmeyer and I are right now, is coming into these roles. This was absolutely what we saw as probably one of our biggest concerns, is just making sure that we have the right service at the right time, the right service at the right time for the families. Because we have been taking sort of a kitchen sink approach is how things have been going. And so what we decided to do is to look at service utilization and really taking a targeted look at what service is being referred and where is that child's acuity. What is the CAN scores? What is the needs of the family, the needs of the youth? And looking at that, we just wrapped up service utilization in Madison County, and we saw some really exciting numbers. Nothing's been finalized yet, but we've seen some really exciting numbers on where we were able to really look at targeted services for families. We're hearing good feedback from providers. We've heard great feedback from families and staff so far. So I think that's where we're starting. We're starting with service utilization, looking at every case, looking at where it's coming in on the front end, where it's at on the back end, and what has occurred. Because we have seen families that have been open for 2.5 years with the same service for 2.5 years, and there's not been movement. And so we're really targeting on how we do that. So that's where we're at right now with it. I don't know if you want to speak to.
I just wanted to add that the tool is the cans that we
Mhm.
typically use to rate where a child's placement is. It's supposed to be a communication tool, but it has evolved into very much how we rate placement.
Well, DCS did a great job. I'm going to give some kudos. On the JD side, they implemented the Colosi, and that is a wonderful instrument if you have the right people around the table discussing the child.
Yep.
And I seen that do a really, really good job. It's but I know it's not implemented across all the counties or the courts or anything like that. It really is helpful to the judge mostly. If that's kind of part of the psychological report that the judicial officers receive. But I really was very impressed because I'm a little bit of a psychometrician, kind of crazy man, but I really was impressed with how well it identified the level of care. Now, the CANS is a little bit more complex in a lot of ways, and you need a lot of training. But if the CANS is as good as the CASI, that's a great thing to start with.
The CANS, I think, is helpful with placement. So where a child should be in placement. The CANS does not help as much on what is the right service for this child that would help bring them back to health. So I have also reviewed the CASI recently. So that could be something we move from the JD side over thinking about how to implement it. We're very much in discovery. Like Amanda said, this utilization project is going into counties we have 20 supervisors that have been there, up to 30 years that just have a lot of experience, and they're working through the lens of our practice models to say, how are we identifying needs? How are we offering services? How are we, checking on these services? How is our team meeting process going? And right off the bat, we've noticed big shifts in Madison County, even in just how we communicate with our providers. So they've been able to take ownership in that county of identifying one person that then will help put referrals out and then answer. Because another thing that we haven't always done well is answer people. So when you are a provider that needs to know how to serve this family and all we put on the referral is keep kids safe, that doesn't give a lot of direction. And so, we're kind of working through those. And it is right now without technology very granular, but I still think it's worth doing.
I just wanted to hop in with something about going back to emergency shelter. And that is, I think, one of the difficulties for the providers running emergency shelter is in the name emergency. So it's difficult to predict. So we have to be ready to take 10 kids. We may have 2. And then from time to time, we will have that where, you have a child who comes in on a Friday night and then they're gone on Monday. And that's great. We think of that as a win. We did what the program set up to do. We kept them safe from the storm, and that did what it was intended to do. And about half of the kids that we have will overstay, so they'll be longer than the 20 days. We haven't seen that to be an excessive amount. So, if they do, then it's more like 10 days and so forth. So then it's a matter of kind of the programming, because while we have them, we want to pour into them as much as we can. So there's not a requirement for independent living services in the service standards for ES, because if you're going to be there overnight, what's the point in doing that? But at the point we say, they're probably going to be here another week or so forth. So we're looking at resources to do that. So we're doing kind of more than is necessary for that. But that's difficult when we're talking about the capacity around the state, because you're not going to have that within every community, and you don't need that, numerically. And you don't need it, based on, the need at a particular time. So that's really difficult. And then Representative Burton, one of the things that you were talking about with the outcomes, what that looks like, is that all of the services that we've been talking about across all the lines, including what we provide, is highly individualized, working with, as we were just talking about, working with the treatment team, with DCS, with everybody involved to figure out what's in the best interest of this kid. So in the last 30 days, we have had a young lady who has had severe mental illness So she has been in the county detention center, moved over to a residential program to NDI for acute hospitalization. And so her outlook is a lot different than those that we have who have worked through the program and are now got 5 kids who are taking classes at Ivy Tech. So, and their outcomes. So it's a little bit difficult to say, what does success look like without looking at individualized, kind of in that results-based accountability model of turning the curve of what was the trajectory of this child and where are they at now? And that's within the scope of our limited time with them, let alone the scope of what, the career of that child looks like. But I think it's exactly the right questions of making sure that we get to the end of that question, is anybody better off because we did all that?
I want to take the conversation back to those 43 kids in the residential facility just for a second. So you mentioned like some of them needing services and going through the process on that and how that looks like. But for the ones that don't need services, do we have a timeline or an ideal in place for how long that they're in that residential facility without being in a foster home, even though they've been recommended for them?
The ones that are already in foster home, or the ones that are already in residential, or the ones that are in emergency shelter care? You know, which
Shelter care.
shelter care? So in the shelter care facility, they do, depending on which one they're in, some of them have programming that they're doing. Others, we do refer other programming outside of other services out to try to work with the youth while they're there. But the entire time they're in shelter care now, they're being staffed on a weekly basis. And then again, on another time during the week, they're being staffed within the local county about what can we do to find a foster home. So there is a constantly evolving staffing on how we can get them out of the emergency shelter care, knowing that it's shelter care. It's emergency and it's supposed to be very short term. So that's kind of how we work it. It's really supposed to be sort of Band-Aid before they go into placement. What we saw though, and what we have been seeing, it's getting better, is that kids were staying a long time and they weren't moving out of shelter care and they were utilizing it as placement because there wasn't bed space anywhere else. Or they couldn't get them to be accepted into a foster home. And so we've really worked on the language and communication with foster homes in order to get them to take these youth and with services in the home, and intensive foster care is part of that, where if it's a youth that maybe they might need a little extra support, we can do that service as well. For our youth that are there, and then we know that they're probably going to need residential care, and then we're working towards that. We're staffing with residential facilities, allowing them to meet the youth and to go over their records to see if they would be appropriate for their programming. And then when they're in the residential facility, they really own the kind of programming around that youth and all the therapy and services they might need.
How are you making the living environment more normalized, like a normalcy thing for them? So being in a shelter, that's traumatic itself. So how are we doing to make it more normalized for the young person living in this place when they really shouldn't be living in this place, but they have to because there's no foster parents?
Sure. I guess can I pass that to you, Jeff, to ask what you guys do with shelter care and how you make it more, more of a better environment for them to be in, to connect?
Yeah, and that's again, it's highly individualized because sometimes the kids, we know the least about them of any of the kids in our services because they kind of just show up on our door. So one of the things we do is we always look at the physical environment and try to maintain that balance of it has to be durable and safe, not things that can be broken and cause hazards and so forth. But as much as we can to try to wrap around that and make sure that it's as conducive as possible to like feeling like they're not in a facility, an institution, or in detention. The other thing is where we have a very therapeutic focus. We have more, and we're very fortunate in this for the moment, in the number of therapists that we have on campus. So there are things that we will do that it kind of exceed the service standards for those. Including the fact that although we aren't required to have a treatment plan for those, we will do a Medicaid treatment plan. So that allows us to kind of unlock reimbursement for additional counseling to do that as well. And then also the communication with the family as much as possible. So as much as is permitted by the terms of their placement, we want to make sure that we're doing as much as we can, including in-person visits or Zoom calls, And the other is just kind of keeping a focus, as we were talking about before, that it's difficult to plan, right? So they may be there a couple days, maybe they're a week or 2 weeks, or maybe they're longer. So one of the things that we make sure is that there's continuity in the education services, because if they are maintaining what they need to do for their home school, that not only helps them educationally, but that's just one more touchstone on normal. So they're kind of communicating with the teacher and with them as well. So then there are other services that are throughout all of the things that we do, including, as I was talking about, the independent living services, the rec coordination and so forth. So I think everybody, those of us who are parents, understand that downtime with kids is not your friend. So part of that is just to make sure that the schedule is packed with productive uses, with activities. It cuts down on a lot of issues. And again, sometimes that's good for keeping them out of their own head, so if they're busy. So just kind of saying, reducing the idle time. The other thing is that through IARCA and the groups and all of us around here and beyond with that too, we're always going to each other's facilities, shamelessly stealing ideas, trying to figure out what those best practices are and so forth. But mainly it's all about connection. So we're making sure that through the schools, the parents, the family, as much as we can, that we're establishing that.
Also, if I could just share a little bit, I know that 20 years I hung out at our juvenile justice center, talking to a lot of these kids, they would commit crimes just to get locked up. The jail's better than their home. So when you say normalized, right?
When I say normalcy, it's more of, do they have to follow what everyone is doing in the shelter or the place, like the programs that they're doing? Or I've had lots of friends that were placed in residential or congregate care because there was nowhere for them to go. So giving normalized of, when you think of folks that are not touched by the foster care system or the juvenile justice system, what does that look like and how can we help improve that?
We got to do better, right? So, and I just want to make a quick comment too on Dr. Brunsma, your comment about the senators needing ICU for their heart problems. I know Representative Burt and I are concerned about half of the Senate needs.
Well.
Analysis of that.
Yeah, I'm very concerned for them, but here, I think the question is really, really good. I don't know who the young lady is down there, but the question is good. The balance for emergency shelter, emergency diagnostic shelter, to try to normalize the environment as much as possible, but understanding that you have to provide security and safety. If you don't have any safety, there's nothing going on. There's no treatment. And you won't be able to keep workers. You won't be able to have a healthy culture there. I mean, I'm looking for a provider just to have another space for another, like, safe passage up in St. Joe. They're looking for another space. And it's been drilled in my head, and they didn't need to say this to me, but I have to find a place that's secure, but looks, like it's adaptable for a normal adolescent to have some freedom and ability, but being able to keep them safe, because the providers don't know what's coming in their door. And, 1 or 2 kids can ruin a whole place in terms of treatment for everybody else. So normalization is kind of like, you almost have to do it and say, okay, how can we do it for this child? And then how can we do it for this program? And can we implement it appropriately? And that takes a lot of work on the staff part. I mean, that's a changeable thing every day, because kids come and kids go. So I do like the fact, though, that at provider side, if you strive for normalization, you'll probably get better outcomes. And because the kids are going to leave at some point, and you want them to leave. That's the normal thing in life, right? So.
Before we move forward, I know Shannon, you've been very quiet there, so I didn't know if you had any comments or questions.
I do not. I love this discussion. I particularly love the young people who are giving, asking questions and giving some of their experience. I think that's hugely helpful to everything that we do.
We're just not used to you being that quiet. That's why I was very good. frozen picture over there or something.
I fear that I'm a giant head on the screen there, so, and it's kind of hard to jump in. Thanks, though.
I do want to add that there is a small number of youth that are not captured here, that are removed and don't have anywhere to go. And so we have the Isaiah homes that we call them non-placement. I mean, I know that's not a super warm and fuzzy name, but the kids that are in non-placement are in Isaiah homes, and they remain, or like homes, there's some that have different names, with a DCS FCM at all times. And then unfortunately, there are times where we have nowhere for kids to go, and they're in our offices. And so this is something I feel very strongly that should never happen. And so we are working pretty hard to close our offices to children, because they're just not the space for kids to be. But those kids do exist as well, and I don't want to lose that while we're talking about, what's available in services. Yeah. Yep.
So, Director, how many kids can you estimate that need really crisis stabilization and diagnostic, or just crisis stabilization? What's our numbers looking like?
Honestly, I don't know that I want to give you a off the cuff number to that. Let me do a little research on that. These kids necessarily, it's not even their crisis. Sometimes we just have them and there's not a place. There's just not anywhere for them to go. There's not a family member that steps up. Some of our kids, while I think that we've done a fantastic job in the JD space with JDAI, so they're not incarcerated, sometimes they're not appropriate, though, for what we have in the milieu in our residential centers now. Because like you said, one kid can walk in and wreck it for everybody else if their behaviors are such. And so those kids then sit in the offices with our paraprofessionals, which I think is not the best place for those kids. And bad things happen. Our staff get assaulted. The kids have access to things they shouldn't have in an office. And so, these are complex situations. We are working with the Division of Mental Health and Addiction with these kids. We have a process in which we staff these kids pretty consistently, but it does still happen.
Probably Jada, her graduation, her degree.
Yeah. Go Jada.
Looking for employment in the social school networking, right? Maybe. So, pray for her to make a big difference in the state. So.
While we're passing out congrats, I have to shout out Amanda Ressler here, who came on in the midst of a tough time at DCS and came on and in an acting status really helped me out as I was in acting status, and then has been recently promoted to my chief deputy. So I'm really proud of her and so grateful.
There you go.
I appreciate that. Yeah, we have a big ship to turn, but we have so many great partners, and so we're definitely going to get there.
This also, just to that point too, what you all don't see is a lot of really good work that happens at DCS. I think that the problems bubble to us appropriately, and that's where we should tackle these as together. But to put on the record, we have amazing staff in the field, and we have amazing staff at central office, and sometimes the problems are bigger than what we can manage alone. So we really appreciate what you're all doing.
Really good.
Did we get through everything on our?
All of us on the list.
So addressing issues, right? So I know we've got this report that I would love for us all to spend time and review questions and answers on the old business side. And I know how do you guys feel that we are doing as far as a task force? I guess that's my concern, right? Are we truly making a difference? Are we making changes? Are we, is the open communication, I think, is a breath of fresh air for all of us. And I feel like we're starting to root for the same team, right? And so I'm encouraged by that, but are we truly making a difference for children in our state? And do you see changes that we can take to the legislature, or do we not need legislation? Is it just procedure, right? Is it working with our courts better? I know we're still openly working on trying to create bringing our judges together across the state to, as far as permanency and looking at those things. And I always look at preventative, right, and getting proactive. How can we, as you said, turn the ship around? How do we help these kids not even get into this, or parents not even get into a predicament where they can't be an adult and parent their children? So I guess I'd like to have a little bit of dialogue on what you feel this task force is doing, and we want to keep it going.
I'll share something that we did to try it, frankly, with Youth Justice Oversight Committee recently. Since we have worked through most of the recommendations in the original report that was established, at the last meeting, I asked every member of YJOC to come from their discipline, from their community, from their perspective, and share what are the top 3 needs or problems within their particular area of expertise. So we got through the sharing of the 3 things at the last meeting, which means that now we're going to compile those, look for common themes, and set to work on those tasks. And so I think that might be helpful in a group like this, because I certainly cannot speak from a provider perspective and know what are the 3 biggest things that you're putting out the fires every day of the week, and how can we maybe help with that? Austin mentions court wait times, and I say, oh, I can help with that, and I'm excited that I can do something about that. So I guess I would like to see this group move from discussion of issues to acting on those issues to improve them.
Just want to throw something in that might be helpful to know. In October, our federal reimbursement for prevention and preservation services increases to 66%. And so that's a really good opportunity, I think, if we're going to look at enhancing those services, that we take the time to think about what we want. So that might be one of the things that we tackle.
Do you think maybe we can all come to the table next meeting and have like a couple bullet points that the different agencies are struggling with?
You mean like ideas on suggestions for things that as a task force we might be able to tackle?
Yes.
I think I would guess that we all have, from sitting here, we all have things that we would prioritize, and maybe it would be a way for us to kind of examine what the different options are so that we could kind of come to some agreement on what might be good things to put forward from a legislative perspective, or what are just things that need a fix that is more, system stuff that doesn't require legislation.
I know one of the things that we talked about this morning at the commission meeting was baby courts, maybe safe baby courts, and that could possibly be something that we take on.
I also wondered if we could do some homework, because if we just wait till the next meeting, then we're not prepared really. That doesn't give us any chance to kind of bring, the background to it. So if everyone doesn't mind to send those forward in email, do we have some way we can communicate back? So that would be, something that we could, at least a couple weeks ahead of time, all of us give our thoughts on it, and then we can narrow it here.
I guess I have a question for Mr. Devon. Is there any legislation currently in statute where there is basically saying that the agencies within the state that work with children and family need to meet and coordinate their efforts?
Is that Austin?
I will say that I do think that is doable. So we have had an interagency meeting that when I came into this role in 2018, we met every month or every other month. And that kind of fell apart during this midstream of pandemic and people retiring and leaving their employment. But I do think that it is something that is doable. I think we need to think about how to make it actionable, because that's, I think, some of the frustration. We would share this information, but then how do we make that
Yeah, I think there needs to be some legislation with it and some accountability from the governor's office to make sure it happens. I'll give you one example that is kind of stares us in the face sometimes. There's a disincentive for the state hospital to take high acuity kids. And the reason is that if they do accept a high acuity kid through a gatekeeper, then the community mental health people back in their neighborhood have to pay for that cost. Well, that they don't want to, the gatekeepers don't want to do that. So that is just built into the system right now. And that doesn't help the state hospitals get any better. And it doesn't really help the fact that we all work with the same children, but everyone's working from their own little silo. And I think the state suffers from the silos. So my recommendation would be to start considering some legislation to break the silos down, that there would be some accountability from the governor's office to make sure that certain things do get addressed. And that this committee should be including the other agencies at some level. I don't know what level, because we're only looking at one little portion of things. And I can tell you, I've seen it for many years, and I've talked to the heads of state agencies. And some of them just feel like, I can't do anything, but you can say something, but I can't say anything. And it's like, that's crazy. So at some point, we're going to have to break that cycle of siloing and bureaucracy down here to actually get things moving. And I really applaud DCS for all the innovation they're trying to do and everything, but you're only one piece of a little system. And the other piece of it is juvenile courts. The variability amongst juvenile courts is incredible, in terms of quality of the judicial officers and who's looking at what. And, there's been a lot of good judges I've worked with, and there are some things where the judge, I used to say, is only as good as the information that they get. But then they do have a responsibility to ask the right questions too. So I do think there's a lot more to be done, but we need the right people at the table. And just meeting with providers and DCS and a few representatives, I don't think it's not going to get us there. It's not where you want it to go. And I would like to put my shoulder to the wheel and say, hey, I'm up for that kind of discussion, but it's got to be more, than this.
I agree. And I mean, my dream is to put you all out of business anyway. So,
Yeah, well, there you go.
But I love the idea of, because we meet every other month and we kind of get refired up, and then we kind of get back to our normal life and we kind of forget about what we talked about. But if we could create that ongoing email or text or whatever, where there's dialogue going on, because you'll have a thought or somebody will come to you with a suggestion or a concern, and we can put it out to a group type email, then maybe we can keep the dialogue going better. And I'm going to put this in Hannah Joy's lap just to, because I know she can do that. And she always did what I used to tell her to do anyway when under me. But I really appreciate y'all being here. It's important. And we got to keep fighting the fight. So we might get discouraged, but don't let the devil win the battle, right? So with that, I'm going to ask Alex to close us in prayer.
Father God, thank you so much for today. Thank you so much for allowing us to have the conversation and bringing all our minds and our hearts to the table. Please continue to watch over us as we do this important work for the state of Indiana and for the sake of this world. And please watch over all of us as we go to our final destination and back to our homes. My name is Jesus, I pray. Amen.
Amen.
Thank you all.